So, good morning and good afternoon. My name is Tamil Kendall, and I'm the director of the Partnership for Women's Health Research Canada, or POWER, which brings together the Women's Health Research Institute in BC, the Women and Children's Health Research Institute in Alberta, Women's College Hospital in Ontario, and IWK Health in our joint mission of better health for all women, trans, and non-binary people through equitable and inclusive research. So I'm absolutely delighted that we're joining today from across the country, from coast to coast, to have our first Women's Health Research Seminar of 2025-2026. And I'm joining today from the traditional territories of the Lekwungen speaking peoples, the Esquimalt, the Songhees, and the Sanik First Nations. And I'm very grateful to be here on these lands as an uninvited guest. And I would ask that we all take an opportunity to reflect on the traditional territories that we're joining from today, and to think about how the work that we do and how we do that work can contribute to reconciliation and also to reducing health disparities for Indigenous women, non-binary, and two-spirit people. So this year's seminar series that we've been doing since 2022 is really special because we are featuring the work of the winners of POWER's Mid-Career Excellence in Women's Health Research Award. And our winner today is from the Women's Health Research Institute in British Columbia. And this award recognizes Dr. Fairbrother's achievements in advancing cutting-edge science, transforming how healthcare is delivered, and also her engagement with community and her role in mentoring the next generation of researchers. So Nichole is a clinical associate professor with the Department of Family Practice at the University of British Columbia, a Michael Smith health professional investigator, and a registered psychologist. She is the head of the UBC Perinatal Anxiety Disorders Research Lab, PARL Lab, one of the only perinatal anxiety research labs in Canada. Her research is in the area of perinatal anxiety disorders with a focus on epidemiology, screening, and new mothers' thoughts of infant-related harm and their relationship with obsessive compulsive disorder and infant safety. She's joined today by Samantha Buchsdruecker, who is an Indigenous maternal health advocate. Samantha is a Cree First Nations woman from Big River First Nations in Saskatchewan with mixed Indigenous and Spanish ancestry. She works with BC Emergency Health Services as an emergency medical call taker, where she's served for over 5 years, supporting parents and families through critical moments of care. Beyond her professional role, Samantha is a community advocate with lived experience focused on advancing cultural safety, sensitivity, and trauma-informed practices within healthcare and social systems. She has delivered cultural safety presentations drawn from her personal and professional experiences to Peace Arch Hospital in White Rock and Legal Aid in Vancouver. She's also presented to UBC's first and second year medical students on children with health complexities, and as a family partner with BC Women's and Children's Hospitals, emphasizing how not listening to parents, especially Indigenous parents, can have a ripple effect long after the hospital encounter. She also serves on the Regional Patient and Family Advisory Council for the Fraser Health Authority, where she provides feedback and insight on procedural changes through an Indigenous lens and advocates for family-centered, culturally safe care across the region. In addition to her health advocacy, Samantha continues to engage directly in community support work. She recently traveled to Edmonton, Alberta, to assist the Bird family in the search for their missing 14-year-old Indigenous son, providing trauma-informed resources such as grief, trauma, and youth counseling supports for the family. She has also supported Indigenous families in reconnecting with their culture, including helping one family obtain their status cards and reclaim their identity. I feel very grateful to have both Nichole and Samantha here with us today, and I'll turn it over to them. Please go ahead.
Tamil, thank you. Thank you very much. That was a lovely introduction of both of us. So thank you so much for having me. I'll just start by saying that I'm joining you today from the unsurrendered territories of the Lekwungen and Songhees nations. I'm an uninvited settler, and I would like, before I start, to acknowledge the Partnership for Women's Health Research Canada and my deep gratitude for this award. I am incredibly honored to have been given this award and excited to be here and have the opportunity to share a little bit of my research with you. So I'm going to go ahead and share my screen and get started. And the way that I'll be doing things today is that I'm going to start by giving a little bit of information and background, and then I will hand it over to Samantha, who will speak for a little bit and hand it back to me. So we'll tag team a little bit during our talk today. So I'm going to be talking to you about new parents' thoughts of infant-related harm, hopefully communicating why I think this is an important topic and how we should be responding to parents who disclose these kinds of thoughts. So I thought it would be fun to start with a little story about how this began for me. So this is a picture of me and my son, my first child, when he was very tiny and very, very cute. And when I had my first child, I can remember having some out of the blue thoughts like, oh, I do love this child very much. I could just throw him out the window and go make breakfast, among other thoughts. And my first reaction to that experience, because I was doing my PhD and I was in a research lab that studied obsessive compulsive disorder, my first thought was, wow, that's so cool. I'm having an obsession just like people with OCD. And my second thought was, I wonder what it would feel like to have a thought like that if you didn't know what I know. What if you were a new mom and it was the middle of the night and it's 4 a.m, you're alone, you have a thought like that, and you don't know anything about the topic of postpartum harm thoughts or intrusive thoughts. And that was, for me, the beginning of research in this area. Very little was known about it at the time. There were 2 or 3 of us who were interested. A really good colleague of mine in the United States was also interested for the same reason. He became a parent and had this experience and was keen to explore further. And so that was the beginning for me. And I think what feels meaningful in some ways is it's clear that this is a really big issue. And yet at the time, many people said to me, oh, this isn't really a phenomenon. This doesn't really happen. And so let me share with you how untrue that is. So I'm going to start by just talking about a particular kind of thought that many of us experience to give context to the conversation about new parents' thoughts of infant-related harm. So unwanted intrusive thoughts are thoughts that we may not want to have that pop into our minds unexpectedly. They can happen in the form of an image, words, or even an impulse or urge. And they are reported by 80 to 90% of the adult population and can sometimes be kind of morally repugnant, like throwing your baby out the window to go have breakfast. So, I think what matters here is that to just be really clear that we all have really weird thoughts. Having weird thoughts is a normal part of being a human being. So I'd just like to ask everybody, you don't need to put your hand up or anything, but just give a little thought to this. Have you ever had an unexpected, intrusive thought about doing something you ought not to do? I don't know, swearing at someone in the middle of a really important meeting, shoving someone in the grocery store because you're annoyed. I think a place where people can really relate, often people who are afraid of heights will have thoughts when near a very high place, a thought like, what if I jump? And so I think it's just good to reflect on our own thoughts and anchor this in knowing that, this is part of being a human being, to have strange thoughts. So what we know is that unwanted intrusive thoughts are more frequent during times of stress. The content of these thoughts is related to our current preoccupations, our ongoing concerns. We notice the ones that are about things we are afraid could happen. That's a really common part of, if we have a bunch of, kind of thought noise in our minds, if a thought that creates fear or is about something we're afraid of pops up, we're going to notice it. And our unwanted intrusive thoughts are personally relevant. So if you think about an airplane mechanic and a pharmacist, you wouldn't be surprised to learn that the pharmacist is more likely to have an intrusive thought about giving the wrong medication, and the airline mechanic is more likely to have an intrusive thought about making an error while repairing an airplane that could result in some kind of accident. So given that these thoughts are more frequent when we're stressed, the content is related to what we're preoccupied with, our thoughts are about things we're afraid of and are personally relevant. Is it really surprising that new parents experience thoughts of harm related to their infants? New parents are super stressed. If you've ever talked to a parent of a newborn, especially their first child, it's the only thing they want to talk about. They're very concerned about their infant safety, and new parents are bombarded with information about infant safety risks. So unwanted intrusive thoughts of infant-related harm occur in kind of two forms. They can be about accidental harm coming to one's baby. So what if I accidentally trip while carrying the baby down the stairs and my baby is hurt? Or unwanted intrusive thoughts of hurting one's baby on purpose. I remember in one of our earlier studies, someone saying, I had an intrusive thought of what if I pushed the stroller off the seawall? For anyone who's familiar with Vancouver, you'll understand what I'm talking about. What we know is that these kinds of thoughts are upsetting to the parents who experience them, and they have a tendency to raise concerns about the potential for child abuse. However, they are most similar to the kinds of thoughts seen in a mental health condition called obsessive compulsive disorder, which I'll talk about in a little bit. So these thoughts are, frankly, startlingly common. So we have conducted two studies on this. John Abramowitz, who is my colleague who I mentioned earlier, has conducted a little bit less explicitly on the accidental intentional harm piece, but he has also conducted research on this. In our own research, with now close to 1,000 people, 99% of our samples of birthing parents report unwanted intrusive thoughts of their babies being harmed by accident. And anywhere from 48 to 54% of our research participants, again, birthing parents, will report unwanted intrusive thoughts of hurting their baby on purpose. And I think this is really important because it tells you that this is a very, very common phenomenon experienced by at least one half of all new parents. So why would parents have thoughts of harm related to their infant? And I think when I work clinically with new parents, they will say to me, okay, look, it makes sense why I'm having thoughts that my baby could be harmed by accident. I get it. You know, I don't want my baby to be harmed. I'm worried about their safety. So I have these thoughts about bad things that could happen. I get it. And, you know, we hypothesize that we may have evolved to experience them because they push us to behave with increased safety towards our infants. But my therapy clients will then say, but what doesn't make any sense to me is why would a good parent have thoughts of hurting their infant on purpose? Doesn't make sense to me. So we also now hypothesize that we may have evolved to experience these UITs, or unwanted intrusive thoughts, of intentional harm because they also prompt us to behave more carefully. So in view of that, I'm going to walk you through a little thought experiment and my apologies in advance. I hope this isn't going to be too jarring. My apologies in particular to Lori on this call. I'd like you to imagine that, and let's make this not too serious. You're on the first floor balcony of a building, and you're with a friend, and you're visiting a friend. She has a little baby, and she said, "Oh, come and look at the view. It's really great." And you're standing on the edge of the balcony. And she says, "Oh, I just have to run inside and go to the bathroom. Can you hold my baby for me?" And she puts the baby in your arms. And you're standing there on the edge of the balcony. And you have the thought, what if I slip and drop the baby? Let's pretend there's grass below. We'll make this not too serious. When you have this thought, what if I accidentally drop the baby? I'd like to ask you, what do you want to do? Does this prompt you to want to do anything? And just think a little bit about what that might provoke in you as what you want to do. And now I'm going to ask you to do this again. Same scenario, you're standing on the balcony with your friend. She hands you the baby. She has to go inside. You're outside alone holding the baby. And you have the thought, what if I just drop this baby on purpose? And I'd like you to think about, what does that make you want to do? Does that provoke the same response or a different response? And I like this example because in our own experience, 8 times out of 10, what people will say to me is the first thought makes them want to take a few steps back. Oh, I just want to back up towards the door or the sliding glass doors of the balcony. I want to sit down on a chair. And when they do the second version of an intentional harm thought, many, many people say, oh, wow, I'm going to run inside and lock that balcony door. And I think this is important because it gives us some information about what it means to have unwanted intrusive thoughts of intentional harm. What if we have evolved to have both kinds of thoughts because they both promote infant safety? And the second type, intentional harm thoughts, are really provocative and push us to really engage in behaviors that increase our baby's safety. So here's where we come to for me, the crux of why I work in this area. If 50% of new parents are reporting unwanted intrusive thoughts of hurting their babies on purpose, it's not possible that fully one half of new parents are abusing their infants. As a consequence, we really want to get this right. We want to know, are these thoughts a threat to infant safety, in which case we need to take action to protect the infant? Conversely, if these thoughts are a normal phenomenon that are not associated with any increased risk of harm to one's infant, but may put one at risk of developing a mental health condition, we would want to engage in normalizing behavior and reassurance to parents. And getting this wrong has serious consequences. If a parent is at risk of developing an anxiety condition and we treat them as if they're at risk of harming their infant when it's not true, we may increase their mental health symptoms and the risk that they develop a mental health condition. Conversely, If they are in fact at risk of harming their infant and we fail to protect the infant, there could also be serious consequences. It really matters that we get it right. So we are the only group that has looked at this question. Most people who've come to this area of research are people who study obsessive compulsive disorder, where it's very routinely accepted that the kinds of thoughts in OCD are not associated with any increased risk of violence. And so people in the OCD area haven't gone there. We decided this was really important to explore. So across 2 separate studies, we have assessed the association between experiencing unwanted intrusive thoughts of hurting your baby on purpose. And again, to be clear, these are not just any thoughts of hurting one's infant on purpose. They are unwanted and intrusive and inconsistent with the parent's values. For example, I really love my baby and want her to be safe. And we've assessed the association between those thoughts and the risk of infant abuse. And across 2 studies, we have found no association. We have applied for funding to replicate this in an even larger sample because there is a little hint of evidence that these unwanted intrusive thoughts of intentional harm may in fact be protective. The raw numbers in our work suggest that parents who report unwanted intrusive thoughts of hurting their baby on purpose may be at slightly reduced risk of actually harming them, and we want to see if that's true, but we need a much larger sample to know for sure. So what we do know, however, is okay, so let's just do this. This is kind of fun. This can help you, because people will say to me, how is this possible? This doesn't make any sense. People are having thoughts of hurting their babies. How is it possible that they are not associated with violence? So I would like everybody to think about the last time they behaved violently. And if you're very lucky and you're a very poised and mature person, you may have to go back to childhood. I'm not going to make that claim for myself. But if you can remember an instance where you, I don't know, slammed a door, threw a magazine, slammed your car door shut, threw your keys on the seat beside you in frustration, how did it go for you? Did it go like this? All day long, you've been having this image, you're making breakfast and you have this image of slamming your car door. And you went for a walk down the street chatting with your kids, and you've got these images of slamming your car door, and then eventually just couldn't take it anymore and you slammed your car door. Or was it more like this? Having a rough morning, you spilled your coffee, something went wrong, your kids are late for school, somebody yelled at you on the sidewalk while you're trying to get everybody in the car, and at some point you just lost it and slammed the door. I'm going to guarantee you that everyone in this room is picking option B. And I think that's really important, because we don't behave violently because we experience repeated recurrent images. It's not how it works. Our negative emotion at some point is bigger than our impulse control, and we lose control of our behavior and act aggressively. And I just think that's really important in understanding how it's possible that these kinds of thoughts are not, for parents, associated with an increased risk of harm. However, they are associated with mental health difficulties, especially depressed mood or postpartum depression, and an anxiety-related condition called obsessive compulsive disorder. I'm going to focus on OCD and then pass this over to Samantha. So obsessive compulsive disorder is an anxiety-related condition, and it's characterized by 2 core symptoms: obsessions, which are recurrent and distressing unwanted intrusive thoughts that the person attempts to push away in some manner or other, with or without either or obsessions or compulsions, which are behaviors that the person engages in either to prevent some terrible consequence or to reduce the distress associated with these obsessions. You can see the connection here with unwanted intrusive thoughts and the things people might do in response to them. And among new parents, when OCD happens during the perinatal period, it is often characterized by obsessions of infant-related harm. And we now have very robust evidence that pregnancy, and in particular the postpartum period, is a time of increased risk for the development like the onset, exacerbation, and recurrence of obsessive compulsive disorder. And I'll just finish up with this slide and pass this over to Samantha. So our recent data would suggest, partly because of the way in which we did our assessments, that we included some good perinatal examples in our assessments, but also because of some changes to the diagnostic criteria for OCD, that OCD in the perinatal period is really, really common. In our two most recent studies, across the entirety of pregnancy, we obtained a prevalence estimate of 6.4%. Across the first 9 months postpartum, we had a prevalence estimate of almost 17%, with new onset cases up to 10% by 6 months postpartum. And so this is really common. Point prevalence is just a 2-week time window. And you can see those estimates are a little bit lower, but they're still not low. And so this experiencing a high level of OCD symptoms, enough for a diagnosis, at least for a period of time in that perinatal period, is really common. I'm going to stop my screen share for just a minute, and I'm going to hand things over to Samantha, who is going to share her experience, which is really lovely, and I'm grateful to her for that.
Thank you, Nichole. Tansei, kinanas kometen, inisi, pikiskiwan, minakisikal nitasanak. Hello, and thank you for having me, everyone. Good morning. My name is Samantha Buchsdruecker, and I'm truly honored to be here today with Dr. Nichole Fairbrother. This topic is deeply personal because back in 2023, I lived one experience that her research is trying to bring understanding and compassion to. In October of 2023, just a few months after giving birth to my second child, Sophia, I went to a local hospital for help. I was experiencing postpartum depression and OCD with intrusive thoughts. That scared me. My obstetrician at the time had told me that if I was experiencing any sort of mental health situations, that I could go to an emergency room for any mental health support and or see my general practitioner. I wasn't unsafe, of course. I was just simply exhausted, overwhelmed, and just wanted to get ahead of things before they got worse. At that time, Sophia was actually born with a serious medical condition, and I had been fighting tirelessly to advocate for her as well. I wasn't sleeping, and I was caring for 2 young children under 2, and my husband was working full-time to keep us afloat. So on October 5th, 2023, I called him and I said, I need you to come home because I need to go to the hospital. I just need some sleep. I need some medication, and I need somebody to talk to. When I arrived at the emergency, everything changed the moment I identified as First Nations Indigenous. The nurse's demeanor shifted immediately, her tone and her body language, everything. She leaned in and said, if you decide to leave, the police will be called. They will find you and bring you back here, and they will have to do a wellness check on your children, even though my children were safe and at home with their father. At that moment, I stopped being seen as a mother seeking help and became a risk to be managed. She told me there would be staff and cameras watching me throughout my stay in the emergency room, and that I would be escorted to a washroom and to get food if needed, and that a nurse would communicate with my husband going forward. I wasn't offered food, and I didn't have my phone, and I wasn't offered a single Indigenous support or resource during my entire stay. And instead of understanding that postpartum OCD can bring distressing but harmful thoughts, they treated it as a sign that I might be dangerous. Hours later, a social worker told me that the Ministry of Child and Family Development, the MCFD, had been called and would be going to my home. She said it was to connect me with resources. But as an Indigenous woman, the daughter of and granddaughter of residential school survivors and the 60 Scoop survivors, I know exactly what that meant. I panicked and I begged them to not take my children away. They told me they'd contact my husband and would keep him informed going forward. When I finally saw a psychiatrist nearly 8 hours later, I told him that I was a working professional with BC Ambulance and that I was safe and that I simply needed help with my postpartum OCD. He agreed that I could go home. When I got home, the MCFD were knocking on my door. For a month, I was lived under 24-hour supervision while caring for my children. My mother-in-law moved in because my own mother, a survivor of the system, was too triggered to be near it again. Even during that time, I kept advocating for Sophia surgeries and care at BC Children's here in Vancouver, often asking them to assign me to a social worker to supervise me if my husband needed to leave, just so that I could be with my child in the room. It took letters from doctors, colleagues, and friends and family to prove that I was safe, stable, and competent. I walked into that hospital for help, and I walked out with a file and a stigma. No Indigenous mother should ever, ever have to experience that. That one experience didn't end when I left the hospital. It followed me into everyday life. It changed how I move through the world as a mother, a wife, and an Indigenous woman. There are small moments that might seem harmless to others, but for me, that brings back everything. I have a couple examples. One example. So a few months ago, me and my husband, we were giggling a little bit back and forth because we had looked at my son's nails, Connor, and his nails hadn't been trimmed. So we laughed and we said to each other, well, we better trim them before the MCFD gets called. It was a joke, but it actually wasn't to me. Because deep down, there's a real fear that Indigenous parents are always being watched and always being judged as uncaring and unfit. Even my husband, who means no harm, doesn't fully understand the grappling effect that the joke has on me because of his white German heritage and upbringing. For him, it's just humor, but for me, it's a reminder of how easily Indigenous families can be judged and targeted. Example number 2. In my home, I actually have many security cameras just for safety and also to keep an eye on my children if I were to step out of a room. When my in-laws, who are white and a German descendants, when they visit from Edmonton, Alberta, they often block the cameras or turn them off. To them, it's probably no big deal, but to me, it's triggering because it feels like they are taking my eyes away from my children, and it echoes generations of Indigenous women who had their rights as mothers taken from them. This intergenerational trauma, it lives in our bodies, our humor, and our reactions, and our parenting. It's the invisible thread that connects the past to the present. What I experienced that day at the hospital is what Dr. Nichole Fairbrother's research helps to explain and to change. Those thoughts I had, the intrusive, unwanted ones that made me so afraid, are actually common among new mothers. They are symptoms, not signs of danger. But because of stigma and misunderstanding, the system treated me as a threat instead of as a patient. For Indigenous mothers, that stigma is magnified. The fear of losing our children is not imagined. It is a fear passed down through generations from residential schools to the 60 Scoop to the modern day child welfare system. When I identified as Indigenous, I wasn't just checked in, I was profiled. And that profile reinforced every generational warning my family ever carried about what happens when you ask for help. Before all this happened, I used to dye my hair blonde. I did that to hide my Indigenous identity, to fit in, to appear clean and proper, and that's how I was raised, to blend and to survive. But after everything that has happened and after being treated differently for simply naming who I am, I made a promise to myself that I will never hide again. I bring a little bit of tears to myself, a little bit of healing. I dyed my hair back to my natural color just yesterday. I began to reconnect to my culture, and I've started learning my Northern Plains Cree language. This journey of reclaiming my identity is part of healing because culture itself is medicine. And that's why I believe so strongly that trauma-informed care must be the foundation of Indigenous maternal care. Trauma-informed care means asking what happened to you instead of what's wrong with you. It means understanding that a mother's fear might come from generations of harm, and healing begins with trust. When hospitals practice trauma-informed care, cultural safe care, they create space for mothers to reach out with fear, without judgment, and without the threat of losing our children. I share this story not to reopen my wound, but to make sure it's not ignored. No mother should ever be punished for asking for help, and no Indigenous woman should be made to feel like a criminal for seeking care. My experience at that hospital was one moment in time, but it represents something much larger. It represents how Indigenous mothers are still navigating a system and that was never built for us. This is why I continue to do this work, to navigate, to teach, and to walk beside families who feel alone in this system. Because healing begins with mothers who are believed, supported, and safe. And because our stories, even the painful ones, are how change begins. Thank you.
Samantha, thank you. Thank you so much for being so brave and willing to share such an important story. And I know I've said this before, but I am so sorry you had that experience, and thank you. Thank you so much. You okay? Okay. So, thank you. So I think Samantha and I decided together sort of where her story would fit in with all of this. And I think we placed it there because I don't have much left in terms of slides, but what I do have relates to what should we do about this? How should we respond to a new parent who shares that they are experiencing thoughts of hurting their infant? And so what I want to say, and I give credit to a very lovely friend and colleague of mine in Italy who developed a much more extensive version of this slide that I'm presenting here. I've pulled it down to some core pieces just to make it a little easier to follow. Whoops. That, you know, new parents can experience thoughts of hurting their babies on purpose in a variety of different contexts. And I think that really matters because it's true that some thoughts of harming one's infant can in fact represent a risk to infant safety. In the context of unwanted intrusive thoughts and OCD, those thoughts are not risk factors for abuse. Generally speaking, they're not a risk factor for abuse in the context of depression. If that depression happens to be accompanied by psychosis and hallucinations or delusions, then there is a risk to the infant. If the parent is suicidal and is believing that their baby can't be left alone, and if they're going to take their own life, they need to bring their baby with them so that their baby will be safe, which can happen in postpartum suicidality, then there is some risk to the infant again in the context of postpartum psychosis, really in extreme bonding issues with the infant, and sometimes complete overwhelm if extreme enough. There can be a risk to infant safety. And because of that, what we really need is to know, well, what situation are you in? And I'm going to get to that in a moment. I'm going to share a little bit with you just how much do care providers currently know about this topic, and then what should we be doing about it, just to finish up. So starting with what care providers know. We have, Samantha came to me maybe year and a half ago to share her story and say, hey, can we talk? And I wish that I could say that Samantha's was the only story, but my colleagues and I who work in this area have multiple examples of parents who have shared that they're experiencing infant-related harm thoughts to care providers and were then monitored for infant abuse, were reported to child protective agencies, had in rare cases their children removed from their care. And to be really, really clear, the risk of those actions is especially high for Indigenous parents. And something I think about a lot is I know that white mothers tell me they have been afraid to tell anybody they're having these thoughts. If white mothers are afraid, I can only imagine how Indigenous mothers feel. That given the historical context and the ongoing racism against Indigenous people in Canada, how an Indigenous person would ever open up about these kinds of thoughts is, I just think, must be very painful, and the isolation they must experience if they don't choose to open up. So from a research perspective, there's minimal amount of research on this, but I'll tell you what we do have. Studies of psychiatrists have indicated that, and this would include US and Canadian populations, greater than 60% would contact Child Protective Services or admit to hospital for severe mental health problems in response to disclosures of these kinds of thoughts. In one study, 38% failed to consider OCD as a potential diagnosis in that context. In another study of healthcare providers, where greater than 50% were mental health providers, 69% were unable to select OCD as the correct diagnosis when given a case description of a parent experiencing postpartum OCD characterized by infant harming thoughts. My master's student, Claudia Cognelli, has just completed a survey of Canadian providers, and again, knowledge is really low. So there's a real gap in knowledge in this area, with care providers being poorly informed about OCD, and in particular, the flavor that OCD takes among new parents. And so what should they do instead? By the way, I love this picture. I hope it's okay. I got a little flourishy by the end of this talk. So what should you do instead? So here it is. Here is what I'd really like to see. You know, when you're playing Monopoly and you get to that place where, you know, you can't go here without going to jail, you can't go to jail without going here, and you can follow this. To me, this is the same. Do not move to child protection in any fashion without an assessment for mental health difficulties. And to me, that's the really key piece. When there is a harm thought disclosure, your next step is an assessment. Is this parent experiencing harming thoughts that are most likely OCD-like in nature, and what they need are mental health services, increased support, education, reassurance, etc.? Or are they experiencing the kinds of thoughts where there is a risk to the infant? And I want to be really, really clear. Even if that assessment includes an assessment of other risk factors for infant abuse, when the thoughts are about harming one's infant are unwanted and intrusive, in themselves, they are not risk factors. Even if there are other risk factors, those other risk factors are functioning on their own. The fact that there are these harm thoughts, those thoughts themselves are not risk factors. And so an assessment needs to be conducted. And it needs to be done carefully by somebody who knows how to do that. If the person has the competency themselves, they can conduct that assessment. If not, they should be referring to someone who has that ability. And part of the reason for that is that if you take a new parent who is experiencing obsessions of infant-related harm and may be suffering from postpartum OCD, and you tell them, we're worried you might harm your baby and we need to do something about that, their OCD symptoms will increase dramatically. You are setting them up to experience more OCD, or in fact, for someone who doesn't quite have OCD, you may in fact tip them over the edge into a mental health condition. Given that the vast majority of infant harming thoughts are not dangerous, and the minority may be dangerous, it's not enough to say what we have heard many people say. Oh, I just wanted to be sure. I just wanted to be safe. Just to be safe. Just to be safe for the infant can mean causing tremendous harm to the parent. And so it's not just being safe. It's actually causing harm when we get this wrong. And so it's not okay just to move to child protection when there's this strong possibility that this is more in the camp of a mental health condition. And I'd really like to see that shift. And for what it's worth, we have a funding application under, say a little prayer for us, funding application under review with the Canadian Institutes of Health Research to test an educational intervention for healthcare providers to educate them about postpartum harm thoughts and how to manage them. So I'm really excited to be able to move forward with that research. Oops. Thank you so much. That's my email in case anyone is hoping to get in touch later if we're not able to answer all your questions in our question period that we have now. So I'll stop screen share, and I think we have time, 15 minutes for questions.
We do. Thank you so much, Nichole and Samantha. This is why I love my job. It's such a privilege to be here and to have the opportunity to lift up such amazing and important research, and also to get to attend and to learn from both of you. Thank you very much. I would welcome for people to either put questions in the chat or raise their hands, and I will acknowledge you and ask you to speak. But from the chat initially, Nichole, there's a question about how you're measuring infant harm.
Yeah, I saw that right there. Yeah, of course, I'm happy to address that. So, yeah, so I'm just going to preface this by saying that for so many obvious reasons, this is a tricky thing to do. Assessing infant child abuse is challenging, and of course, there's always a risk with self-report that people may not be fully open. So my team is right now just finishing up a meta-analysis of the prevalence of infant abuse, and I think one of the things that I found really reassuring about that, obviously a heavy topic, but what was reassuring when we did this is that everyone who's doing this well has been using a similar assessment method to us. So yes, it's true that we do ask parents to self-disclose, and we have a questionnaire for that. And I've given some talks actually to ethics boards about our methodology because we did backflips to ensure that the data we obtained on infant abuse was anonymous. And we shared with our research participants all of the steps that we were taking to ensure that the data they provided we would be unable to trace it back to them, that they would be unidentifiable. And because in our most recent study, we were collecting data at 3 time points, this got really fancy. So we had a USB stick that was a very special, expensive USB stick that could be erased, etc. And it was we had the contact information and the participant ID code in that one location. And when we would receive their data, we would immediately go and make the disconnection between their ID and their identity. And then we'd hide that in a locked briefcase under the desk. It was all very spy-like. And one of the things that I think is worth mentioning in this whole process is that we had actually had a heck of a time initially with our ethics board that was concerned about us collecting this data without being able to take action to protect infants. We made the argument that if we could take action, the data would be useless. There would be nothing. We wouldn't be able to collect the data because the data would be of such poor quality that we would learn nothing. And we felt that the learning was important. So we actually received a letter of support from the Ministry of Children and Family Development in British Columbia in support of our study methodology that allowed us to move forward with this research. So I hope that, Peter, that was a helpful answer to your question.
It certainly speaks to your commitment to rigor and continuing to jump and negotiate, and in order to do the research in the best way, Nichole, which is...
Oh, that's very kind to Mel. Thank you.
Which is impressive. Joe Finn has also asked a question in the chat about what you think about what sort of interventions might be helpful with preventing ACEs.
Oh, wow. I mean, I have to apologize and say that my relationship with child harm research and childhood trauma is very anchored in this particular area. And obviously, there is so much that needs to be done to reduce the risk of ACEs, in particular, some of the more serious on that list, child abuse, obviously. And I think obviously a lot of support and education and mental health treatment, etc. But that would fall really outside of my areas of expertise. My apologies.
I'd like to ask a broader question of you, Samantha, if I might. We have, as you know, in British Columbia, the health authorities, many of the professional associations have made a commitment to advancing cultural safety in the healthcare system. You work for BC Ambulance, so you know what happens as a worker inside the system. And I'd love to hear your thoughts about what are our priorities and next steps, particularly in the perinatal area, for addressing anti-Indigenous racism in the system. You know, what do you think is necessary? Because we've got the policy commitments. Now, how do we move it into practice?
I've actually kind of been working on a community-led project myself to kind of try to complement helping women and Indigenous women that are experiencing any sort of perinatal mental health, and also bringing in a little bit more of a cultural aspect to it too, and focusing more on Indigenous women. But through my initiative, what I've been doing is I've been trying to connect with friendship health centers, and I've actually connected with the Semiahmoo First Nations here in White Rock, BC, and I'm going to be connecting with the Coquitlam First Nations as well. Just trying to collaborate with the chiefs and with the councils on the First Nations, and just trying to get that this information that we're doing and this work that we're doing behind the scenes is happening, and that the community needs to know, and that where my initiative is going to fall into that is where I'm going to bridge that gap. So I'm going to try to essentially become a consultant or a family navigator, and bridging a gap between families and community resources that are out there, but that are very unknown. Like, there are very many perinatal resources. So like postpartum, national postpartum, I'm not familiar with the actual name, but there is many resources for perinatal mental health out there that I actually didn't know of before I got into all this work. And when I had got into this work and I started to communicate with other mothers and kind of just started to ask questions in the community, a lot of mothers don't know that there's these resources out there, and that we're kind of just left on our own. So what I'm trying to do is bridge that gap between community and systems. I hope that answered your question.
It did. Thank you so much for the work that you're doing in community, and for making that community-led real. So important. Nichole, there's another question from Agnes for you in the chat about how whether or not these tools are validated as far as the measurement of infant-related harm thoughts. And are there frameworks to help identify when these thoughts become clinically significant?
Yes, of course. Thanks, Jamil. So we use a measure that we nickname the PIPI. It's the postpartum intrusions inventory. And it's a kind of amalgamation. It's similar to John Abramowitz has a measure similar to ours. He doesn't discriminate. He doesn't focus on harming thoughts and discriminate accidental and intentional where we do. He uses a similar process. And our measure is an amalgamation of a list of perinatal specific thoughts and a very well-validated measure for OCD called the Y box. And what we have done is we have created an extensive list of thoughts of accidental harm that parents may experience in relationship to their newborn infant. And we ask them which of those thoughts they have experienced and how frequently, etc. And then in response to that, they are asked how distressing those thoughts are, how hard they work at pushing them away, how interfering they are, etc. And those are from something called the Y-Box, the Yale Brown Obsessive Compulsive Scale. We have modified some of the Y-Box items to make them more perinatal relevant. We have begun the validation of that measure. We've used it across several studies. I feel really confident in our measure, but unfortunately, we have 16 variables that require some extensive coding, and we now have some lovely, lovely medical undergraduate trainees who are working in our lab and who are going to be helping with that. And so I'm very hopeful that by Christmas, we can move forward with writing up that paper and formally publishing our measure. In the meantime, John Abramowitz's measure is out there, and I'm also happy to share our measure. If anyone wants it, I'm happy to email it around. So that's kind of where we're at with it.
Thank you very much, Nichole. I think we have time for one more question. So I'm picking up from another one in the chat. Nichole, you said after disclosure of unintentional infant-related harm thoughts, you said, okay, the next thing that you should do is assessment. And if you're qualified to do assessment, you do assessment. If not, you refer. If you're not qualified to do that assessment, what are the kinds of helpful things that as a frontline provider, as a primary care provider, that you could you model for us what we could say to the woman or birthing parent in front of us that would be helpful?
You know, it's funny when you ask a question like that, what the feeling that comes across me is just, oh man, I'm just running as fast as I can to get as much done before one day I have to retire, because there's just so many things to do. And I think that, you know, while we will be providing education to care providers, the obvious next step is to develop really good training so that they can do these assessments, and then to roll out that training as broadly as possible. And, you know, there are multiple steps for us to be able to get to that place. In the meantime, Neil, I can send you some of these measures and other things that you could then share with the group of attendees if you would like, if that's something you're able to do. But our research lab has an infographic about infant-related harm thoughts. That's quite lovely. We have an animated video that we're in the process of testing, so we're not able to distribute yet, but in about 6 months, we should be able to share that as broadly as possible, hopefully. And our website also has some nice information. So from an educational perspective, I think it's important, you know, if I were working with a new parent and I wasn't competent to conduct this safety assessment, what I would probably be saying is, hey, you know, most of the time for the majority of parents, when they're having thoughts like this, they are not dangerous. However, and here's some education I can give you about how they normally play out for people. But, you know, this isn't an assessment I'm competent to do. I need to refer you to somebody who feels like they're able to do this assessment well. And, you know, I'd like us to do this in as nice and collaborative a way as possible, because I know we both want your baby to be safe. And then you hold your breath a little bit and hope that you can make a referral that does not result in an experience similar to Samantha's. And I would say that is still in some ways a little bit tricky. There are some care providers. In fact, I would estimate a chunk of care providers, 20-30% of care providers, who have enough information and education that they can do these assessments, and they understand that for many new parents, this is a normal, common phenomenon. And that isn't everyone. And so we really are working very hard to shift that landscape.
Thank you very much, Nichole. Thank you, Samantha. I am confident, and this is based on her track record transforming what we do around perinatal anxiety in Canada. I am very confident that Nichole's research and her knowledge translation will lead us to a better place around infant-related harm thoughts. Congratulations again on your Power Mid-Career Excellence Research Award. It's been such a pleasure to be here with you, and I want to thank everyone that attended. I will circulate these materials to the distribution list. And please follow Power on social media, subscribe to our newsletter, our Eventbrite, stay up to date with us on what's happening. I wish everyone a really good rest of the day, and so much appreciation to the two of you for this excellent talk.
Tamil, thank you so much.
All right.
Thank
Bye,
you.
everyone.
Bye-bye.
Bye.